attendees, which is absolutely fabulous. Welcome everybody to this webinar, ERS webinar on inhaled antibiotics. I hope everyone is safe with the current COVID affairs and everybody is keeping healthy. It's a very broad topic, but we have a very brave and very good speaker tonight who will tackle the very broadness of this topic. Well, first and foremost, the practical aspect. So we will first listen to Dr. Eva Polverino, who will give us a talk on theory and some clinical cases as well, just to get us some exercise. This will last more or less 40 to 45 minutes. In between, if you have any questions that pop up, please put them in the webinar chat. I will summarize them, and at the end, we have 20 to 15 minutes where I can pose, Dr. Polverino, the questions that you have put into the webinar chat. And by that, I would like to welcome you all, and I would also like to introduce our very honorable speaker, which is Professor Eva Polverino. She has achieved her medical degree in Napoli, in Italy, and her PhD in respiratory medicine at the University of Pisa, also in Italy. She's currently working in Spain because after her training and research on pathophysiology on respiratory diseases, she started working in the field of clinical and translational research, and she developed her major experience in this field as a postdoctoral investigator at Fundació Clínic of Barcelona, where she was an associated professor from 2014 till 2016. She's currently working on CF and non-CF bronchiectasis wards, where her main lines of investigation are in fact CF and non-CF bronchiectasis, but also community-acquired pneumonia and healthcare-associated pneumonia. She's the current chair of the Assembly 10, ERS Assembly 10, which is the Assembly on Respiratory Infections. And she's in many other endeavors, such as the MBARC bronchiectasis consortium. She's also in the IABC, which is very relevant for the talk of tonight, which is the Inhaled Antibiotics in Bronchiectasis and Cystic Fibrosis Consortium. And by that, Eva, I give you the word. And so if you have any questions, put them in the webinar chat, and we will summarize them at the end for Dr. Polverino.
Thank you very much, Peter, for the nice introduction and for calling me brave. I know I need to be brave to cover this topic because it is very broad and diverse. As diverse is our audience, so I'll try to cover, the most relevant aspects. Some of them more theoretical, some of them more practical. I'll try to do my best, and then we will see whether I can answer most of the questions you might have. So this is the title. We're going to cover inhaled antimicrobials. This is my conflicts of interest. And let's go to the first slide. So just to let you know what's the idea regarding this webinar. Of course, we want to have a rough idea of advantages and disadvantages of using this kind of drugs, particularly with this kind of administration inhaled. And then we'll try to have an idea about who are the patients candidates for this treatment, then how to prescribe, how to use these drugs, when, and then 3 final clinical cases taken from my practice, right? So I think we can try to answer most relevant questions. So the first thing, of course, would be what's special with inhaled administration antimicrobials? What are the pro, for example? Of course, if you use a topic administration like the inhalation one, you will expect to have reduced systemic side effects because the antibiotic mostly goes to the airways. The level of absorption is really, really low. It means you can achieve a high concentration locally in the airways where you're supposed to have the infection, the site of infection. And due to the high concentration, the risk of antibiotic resistance occurrence is much, much lower. So these are the main advantages of this administration. But we do have disadvantages, like local side effects, bronchospasm for many of them. Of course, for any kind of antibiotic, you could induce some kind of microbial selection. If you're trying to kill a specific bug, you could make easy survival on a different one as ever for any kind of antibiotic. The other thing is patient compliance. Not all patients are really compliant with this kind of inhalation. It takes time, okay, and needs some expertise, needs some instructions. And the last and not less relevant aspect is drug and nebulizer availability. They're not available everywhere. Indications are not approved for all situations. So it could be quite difficult. So you always have to have a pro and con balance at the end if you think to start this kind of treatment. So let's start with the first question: who should be candidate for this kind of treatment? And I will show briefly, okay, what we already have in the literature and in clinical practice. So the 4 main groups of patients that have been, I would say, they have been receiving inhaled antimicrobials are intubated patients, like mechanically ventilated, ventilator-associated patients, intubated patients, ICU, cystic fibrosis, COPD, and bronchiectasis. Now, down the first, under the sickles, you will see 2 rows. The first one shows you the kind of evidence we have regarding inhaled antimicrobials, the time of experience we have. You see the longest one is for cystic fibrosis, more than 30 years using inhaled antimicrobials, but also for intubated patients, more than 20 years. Much less experience has been gained with bronchiectasis and even less for COPD. For the 4 kind of patients, these antimicrobials have been used for 2 purposes: to prevent or to treat a specific infection, right? And then the second row, the lowest one, will show you elements that should consider as peculiarities of these patients groups, right? The microbiology is not the same in an intubated patient, in an early infection, or a late onset pneumonia, an intubated patient. Cystic fibrosis has specific microbiology that could be different from bronchiectasis or COPD. So microbiology is always something that makes difference the population. Risk factors are completely different. For example, intubated are completely different from bronchiectasis or COPD. And the main issue is the circuit. It is always closed in intubated patient because inhaled antimicrobial nebulization goes to the closed circuit of the ventilator, and it's always open in the rest of other patients when spontaneously breathing, of course. Let's go to specific ones. So intubated patients, you see here an example. You see an example of a device that is often used. You can see a kind of T connection that had to be interposed within the ventilator closed circuit. The main differences here is that the device is placed into the ventilator circuit, and that delivery of the drug has to be coordinated with the ventilator cycle. So you need to know what you're doing to make the overall stuff to work properly and safely. Okay, so what do we have? If we look at the literature, we have a number of papers showing that inhaled antimicrobials have been used in the ICU to treat nosocomial pneumonia, right? This is a systematic review showing, unfortunately, no differences in all-cause mortality or microbiological success or toxicity. However, these authors say there is not enough evidence to discard their use. We still believe there could be a benefit from the administration of this drug in some patients in some circumstances. So there is still some positive idea about this. But inhaled antimicrobials have also been used to prevent. And you can see a different meta-analysis where the analysis has been done for mortality, right? With uncertainty, if you look at the combined effect, it is not clear. It's not clear. There is no clear benefit. But if we look at the analysis at the bottom of this slide for the occurrence of ventilator-associated pneumonia, the combined effect seems to be favorable for prophylaxis. So some beneficial effect could be. So again, it is not clear, but some effect. Otherwise, it is important to know that some non-comparative studies have suggested increase in the emergence of resistant bacteria. That is, in the ICU, we tend to use antibiotics for prolonged time. And it is, as usually, if you're trying to kill a bug, it is obvious you could facilitate survival of another one or the emergence of some antimicrobial resistance. That is always expected. CF. It's a completely different word. This is an old picture that just simply wants to show you how important the chronic infection is in this group of patients, right? More than 60% when they become adult are chronically infected. Most of them show bad bugs, we could call them, right? Like Pseudomonas aeruginosa or Staph aureus, Achromobacter, and so on, Burkholderia. So the prevalence is incredibly high. That's the reason inhaled antimicrobials have been used since many times. That's the reason we have so much experience in that. And this is a beautiful slide from the CF world that simply shows how relevant these drugs and this formulation has been for these patients, changing literally their life, the life expectancy. So you see the survival curve over the time, right, according to the introduction of different drugs. So you can see if CF patients were expected to die when they were young, in the previous century, you see that life expectancy has become better and better according to introduction of new inhaled antibiotics. And you see today, they're very broadly used. It is like routine for them. They made a real big difference. Sorry. What do we have in COPD? Very few things, right? Very little experience, but even in this patient group, there is a nice paper published a couple of years ago from a Spanish group, right, close to Barcelona, showing that 36 patients with COPD, chronically infected with colistin, were started on, chronically infected by Pseudomonas aeruginosa, were started on colistin, and they were followed up to 5 years. And you can see that the number of admissions went down dramatically as the number of hospitalizations. That seems to be beneficially. Of course, there is always a lot of concern about the tolerance, but it is important to understand, as we will see later, that whenever you use an inhaled drug, you should follow up your patient to make sure that patient is doing well the treatment and is able to tolerate it and eventually adapt, correct what can be corrected in their administration and also adapt the regimen to specific indications and needs. So this is what we have. In bronchiectasis in the last year, we've had a lot of trials. The first one was the ASLE trial with inhaled aztreonam that was initially negative, because even if we had a good microbiological response, if you look at patients on inhaled aztreonam, you can see the number of bacteria going down. But clinical response in terms of quality of life questionnaire did not significantly change in comparison to saline solution that was used as placebo. To be honest, there are two main things to say. First, saline solution is a treatment itself, and we know it very well today. So possibly the comparator was not very good. And second, there is a post-hoc analysis recently published showing that patients with high bacterial load did have a significant increase in quality of life. So probably the new design would show more clearly the benefits of this treatment. Then we had the RESPIRE 1 and 2, two identical trials with inhaled dry powder ciprofloxacin, showing contrasting results. The good thing is that they attempted to identify differences between 14 days regimen and 20 days regimen. Unfortunately, results were not clear and the drug was not approved after that. But it is to say that a number of concerns were raised after that because of the kind of patients that have been selected. So we were not absolutely sure that patients recruited in the second trial were the appropriate ones. Orbit 3 and 4, similar design, but liposomal ciprofloxacin. A good trend to, in terms of benefit for the in liposomal ciprofloxacin, although the statistical difference overall was not, absolutely clear, so it wasn't approved at the end. And finally, the colistin trial that was using continuously this inhaled drug for 6 months, and you can see on the right that there is a benefit in terms of exacerbations. Patients on inhaled colistin had much less exacerbation. Unfortunately, the expected statistical difference was not achieved unless patients with a good compliance to treatment were selected. That was not the initially primary outcome. But again, we are seeing that a lot of the results depend on how the treatment is done, right? And on how patients are selected. The second question would be how? How do we use inhaled microbials? And again, there is a big difference between patient under mechanical ventilation and patient on spontaneous breathing. So it could look complicated. This is the slide showing the problems we might have in intubated patients. So on the left side of the slide, you see what are the limitations for intravenous antibiotics. We do also have a lot of problems when using intravenous antibiotics. First, does the antibiotic have enough pulmonary tissue penetration? Not all the antibiotics are the same, particularly in these conditions. Under mechanical ventilation, there is a lot of ventilation perfusion mismatch, and this should be taken into account. The same is regarding distribution volume. It is not the same. Not as a spontaneously breathing patient. It could be quite common to find an increased distribution volume. That means you need more antibiotic than usually. And of course, microbiology is specific to ICU, and you could also induce a selection of MDR pathogens, and adverse events are also to be expected. On the right side of the slide, what factors influence or limit the administration of inhaled microbials in the ICU? A number of factors. You see, some of them depend on the ventilator type, some of them on the device you use to inhale. Some of them depend on the drug or the patient. But keep in mind that the position of the drug is influenced by severity and extension of pneumonia, humidification of the system, the ventilatory circuit, okay, and ventilation parameters. If you want a good distribution, you need a laminar flow. If it is a turbulent one, there is a lot of dispersion and deposition of the drug along your circuit, particularly if you have some angles, and this makes the deposition into the lung much more difficult. So it is not easy. So you need some practice, but consider you might have limitations on both sides. What do we need to know for spontaneously breathing patients? So first of all, it's not so easy, because your spontaneously breathing patient might have such a thick mucus, like this figure you see here. This is a sputum. You see the container is upside down, and the sputum does not move at all, showing how thick it could be. So usually we do suggest to use bronchodilators first to open your bronchi, physiotherapy to move up sputum samples, and then apply antibiotics. The right sequence is really important. Second, tolerance test. All your patients should be tested. You cannot just prescribe inhaled colistin, for example, send your patient home with that specific treatment. You need to see whether the patient tolerates it at that time and even after 1 or 2 weeks, because some, for example, COPD patient might tolerate the inhaled antibiotic at the beginning and not after 2 weeks, because they sometimes develop some dyspnea because of increasing bronchospasm. So follow-up is as much important as the initial tolerance stance. So you need to keep in mind, you need to choose the right antibiotic, the right regimen, and the right device. Let's go a little bit deeper in it. You see, different devices are available, specific characteristics. Some of them have been specifically developed for a drug, like a bit INEP. You see here the blue one on the bottom, because of the volume and the kind of administration was developed for colistin, a specific colistin, or for other drugs for pulmonary hypertension. And some other devices can be used for different drugs, like the eFlow. Okay, or the PI, this one. So different devices, some of them bigger, some of them smaller. Usually they need electronic plug, you know. Some of them are nebula, and if you look on the right side, some antibiotics are nebulized, some other are dry powder, like the Tobipot Haller. So you don't need an electronic powder, they're smaller, no humidity. But the point is, are they all accepted? No. That is the point. That's the reason they are not available everywhere. Sometimes public health cover their costs, in other countries it does not. So all these inhaled antibiotics are accepted for CF, but not, for example, for bronchiectasis or COPD. So it's something you have to consider. Although we broadly use both of them, they are only officially accepted for CF. So when you use a specific antibiotic, you should consider a number of elements, right? The tolerance. So the tolerance of that drug depends on antibiotic, on the specific device. You could have the same drug that is accepted, tolerated with one device and not accepted with another one. Maybe the patient could also have asthma. So in that case, the tolerance could be very limited. If the patient has any allergy, it could be related to antibiotic, to excipient, any other infection. Are you choosing the right antibiotic? If you have two infections, what would you do? Which one of the two would you treat, right? And then again, do you have that drug? Is that accessible or not? Has the patient any other comorbidity? So it's not so easy. And then the right regimen. We have seen trials were done with continuous antibiotic trial like colistin, or the oldest one that was done with gentamicin. Some other trials where they were done with 28 day on, 28 day off, some other 14 and on and off. So to be honest, if the concern is antibiotic resistance, we haven't seen from a clinical perspective any real problem in terms of antibiotic resistance, right? For two reasons. First, because the local concentration is so high that we do not really see clinical consequences of a specific antibiotic resistance. Second, because the susceptibility tests we usually have are done on blood, on systemic, and on the base of a systemic administration of drugs, not based on the inhaled administration. So they are not the right tests. Now, the second point, 14, 28 days, although we had the RESPIRE trial, it is not clear. It is quite uncertain. And nowadays, it's not even clear if we always have to do on-off or continuous. The more we go ahead, the more benefits we find for possibly continuous instead of on-off trials, possibly because the patient feels much better. Resistance is not a problem. So in many cases, we do have continuous treatment, or we also need to alternate to different antibiotics on alternate months. Let's go there. Then the right device. So again, a powder, a nebulized solution. You need to consider a number of factors like ease of use for the patient. You need time. There's some space, right? You need electronic plug. Is that easy to clean? So, you know, imagine a very old person. Would that people be able to clean, to store everything? Now, again, the drug delivery devices are not the same, all the same. The vibrating mesh devices are always preferred to other ones, right? And then another factor that could help you understanding what the patient is doing with the treatment is if you have a monitoring system. That is the case for the INEP1, for example. And another aspect would be, is your device usable for different drugs? That could be the case, for example, of eFlow Rapid, where you can use different drugs with the same device to nebulize. Otherwise, the INF, for example, is very effective. It develops, it delivers the drug just during the inspiration in a very efficient way, but it can only be used in most countries for a specific drug. And then you need your patient to be collaborator, usually. So it is important to check whether they use it in the proper way. When? So what about mechanical ventilation? Despite all positive force, unfortunately, guidelines cannot recommend the use of inhaled antibiotic because there isn't enough evidence. Even the last trial with inhaled amikacin that was added to intravenous therapy of ventilator-associated pneumonia for gram-negative pneumonia couldn't achieve any benefit, couldn't show any benefit. So unfortunately, we do not have any clear benefit, even though we still think that adjunct, they could be used as an adjunct therapy, particularly for multi-drug resistant infections, severe non-responding pneumonia. What do? The patient is not responding. You try almost everything, right? So even particularly after a long time of ventilation. So sometimes they are added, they are very commonly used despite the lack of evidence due to this, possibly the lack of good trials, probably. What about spontaneously breathing patient? What about acute infections? They're not very indicated. Why? Because the inflammation goes up in the airways. So the use of inhaled antibiotics could even increase side effects. So they have not been shown to be very useful in the exacerbation. They are used sometimes for the first infection by specific pathogen like Pseudomonas aeruginosa. They can be used for an eradication attempt, but not for pneumonia, not for an acute infection. They are mostly used for chronic infections to prevent exacerbations, to improve quality of life, to improve symptoms. The point is that the only clear indication nowadays is for CF, although again, they are broadly used for a number of the other indications, COPD, bronchiectasis. Just one slide to remind you that we're not talking only about antibiotics. We also have antifungals like pentamidine or liposomal amphotericin. Liposomal amphotericin is becoming more and more frequently used. Why? Why? Because we have a number of immunodepressed patients that go into severe problems with respiratory infections by different fungi. So it is very common to have patients with a chronic fungal infection. It is not aspergillosis I'm talking about, and not allergic aspergillosis. I'm talking about severe aspergillosis due to immunosuppression, like transplanted patients or patients using different kind of treatment. So in general, you can find these kind of inhaled antifungals in CF, in bronchiectasis, or after lung transplantation. The point is take care of environmental contamination that could be serious, and consider that this solution, particularly liposomal amphotericin, is very difficult to inhale because for me it's sticky, it's thick, so sometimes it takes a longer time than usually. You have to dilute it a bit. Sometimes it could take a bit longer. Anyway, it's a very good solution, particularly for long-term treatment of fungal infection. After at the second stage, you could start with a systemic antifungal treatment and then continue a long term with the inhaled liposomal amphotericin. Now, I think we can start with clinical case. Peter, what do you think? Do we start with clinical case or should we stop for questions?
I think you can go through with the clinical cases and then afterwards we can summarize the questions, Eva.
Okay, good. So clinical case, we have a quite young male, non-smoker, 2 kids, rheumatoid arthritis, on steroid treatment and methotrexate, okay? He had some bronchiectasis, he was on follow-up in my clinic. And he had only one isolate for Pseudomonas that was eradicated after a simple 2-week cycle of ciprofloxacin. Then he came suddenly to the emergency care because of high fever, clear respiratory failure, right? Pleuritic pain, diarrhea, and he had this chest X-ray but he had a very bad oxygen saturation, a very high respiratory rate. So he was quickly intubated and went on mechanical ventilation. You see blood test, leukopenia, C-reactive protein high, but not particularly. Think this guy was on corticosteroids, low platelet count, even coagulation disorder. So any kind of test was performed to identify the microbiology, right? Bronchial aspirate, as soon as it was intubated, urinary antigens, blood culture. So what would you do? What kind of antibiotic therapy would you use in this case? You see a long list, yeah? So I would like to ask you to vote. Take your time to read it. You see there are different combinations, right? Take your time and choose one. It does not necessarily mean there is only one right answer, right? But give your opinion. What would you do? There are different options here. Some of them are similar. Young patient, bilateral pneumonia, severe respiratory failure. What kind of antibiotic therapy would you choose in this patient? Okay. Can we see the response rate we have? All these cases are real cases, right? Patients of mine have been treated in the last years. Ali, can we see the responses? Okay, so the highest proportion would be for the second one. Okay, so 2 Pseudomonas intravenous antibiotic, right? Good. I'll close it. So I'll tell you what it was done. Yes, there was, this is why this combination? First, because we are covering at the same time with these 2 antibiotics, we can cover Pseudomonas aeruginosa, right? 2 antibiotics because it's a pneumonia. And if we assume this patient might have Pseudomonas aeruginosa, we tend to use 2 antibiotics instead of 1. But this guy had to be considered immunosuppressed. So it was also added the cotrimoxazole, thinking of a potential fungal pneumocystis jirovecii infection, right? So let's see what happened then. When we had, after a couple of days, we had the results. Strep pneumonia was almost everywhere. Positive urinary antigen, bronchial aspirate, blood culture. In 2 days, everything was clearly positive, but also Pseudomonas was there. So we had 2, not 1 bug. Was our antibiotic therapy correct? I think yes, but we had something we could possibly remove the cotrimoxazole because pneumocystis jirovecii was discarded. So this slide shows you differences in terms of microbiology, right? Because when you have an early onset pneumonia, right, the patient arrived at the emergency care from home. So that had to be expected as the community-acquired pneumonia, right? So this is the most common microbiology. Sensitive areas, strep pneumonia, Haemophilus influenza. You see, like a community-acquired pneumonia. It would be completely different if we had a patient with a prolonged mechanical ventilation, intubated more than 5 days ago. So you would expect to have Pseudomonas. The point is that this patient had bronchiectasis and had Pseudomonas at least once. That's the reason we thought to use a combination of different drugs. Again, it doesn't mean it's absolutely right and the other response that was preferred by most of you was incorrect. At the end, it was correct, right? Anyway, as we saw it was strep pneumonia and Pseudomonas, we decided to cover with ceftazidime and amikacin, right? But the point is, was in this case inhaled antibiotic a good choice? Not at all, because it is a pneumonia, an early onset pneumonia. So this is not an indication. We say that in ventilated patients, we could consider just an adjunctive therapy in complicated cases with MDR and other problems, lung ventilation, and so on. So this was the first case. Second case, 34 years, male patient, no allergies, triathlete, right? Cystic fibrosis. Young male, but was diagnosed very early in the infancy, 2 months of age, because clear, delay in growth. Sweet test clearly positive. Genetics test clear to the diagnosis of CF. At that time, he's today is one of my patients still. So he has bilateral bronchiectasis. You see the kind of CT scan. You can see he's diabetic, pancreatic insufficiency, everything because of the CF. Is chronically infected by Staph aureus, sensitive to methicillin, and he had just once Pseudomonas aeruginosa had been successfully eradicated. He's competing in triathlon. Look at his spirometry. This guy is incredibly fitted. He's very compliant with everything, and his general status of health is very good. Sorry. Here. Then he came to my clinic saying, "Oh, I feel so bad. I cannot eat. I've lost quite a good, cycling is difficult. I've lost some weight, and I've started to have some blood in sputum. I'm tired. What's going on?" So this was the new spirometry. He had lost 5 kilograms, and his saturation, that usually was quite good, had gotten down to 92, 93%. As usually, at every visit, we do microbiology of sputum. And that's what we had, right? Mycobacterium abscessus as subspecies. And you can see are everywhere. It was resistant to almost everything, but in particular, genetic tests were done as required for this kind of infections for macrolide. So it was resistant to macrolide, and it was sensitive to aminoglycoside. What kind of treatment would you choose? Would you like to vote? So you see, first option, that is like normal TB, mycobacterial infection, kanamycin, because it was positive in the susceptible test, kanamycin, inhaled amikacin, meropenem, or Cipro, as usually because it had Pseudomonas aeruginosa, inhaled amikacin, oral azithromycin, or a similar combination to the first one, or again, 2 intravenous, like meropenem and aminoglycoside, 1 or 2 oral drugs. Decide, CF patient, usually Staph aureus, just once Pseudomonas aeruginosa, hemoptysis, weight loss, abscessus. Typical situation. Okay. Can we see responses? The responses here? Okay, good. Good. Okay. So your the most voted answer is the last one. Okay. I showed you what we did. The last one. Of course, everything was resistant, but as I told you, sometimes clinical response is different from what we see in the susceptibility test, and this is particularly true for NTM infections. So the difference can be really important. So we have to go to guidelines. What do guidelines say? So 3 to 4 drugs at the beginning, usually 2 intravenous for the initial phase. And after 3 or 4 months, depending on clinical response, you might decide to change from intravenous amikacin to inhaled amikacin. So in this case, we used, let me see, yes, this is what we did. We used imipenem, we used amikacin, we added clofazimine, right? And after 3 months, we stopped inhaled amikacin and we changed to inhaled one. So it tolerated very well the treatment. It's a heavy treatment, but I don't know the reason. CF patients do tolerate almost everything. They have a different metabolism. So first 3 months, he was doing incredibly well. So we stopped after that inhaled amikacin, intravenous amikacin and meropenem. He continued on oral clofazimine. We added an oral one because we always want 3 drugs. So we added linezolid and we started inhaled amikacin. 1 year later, he's doing very well. He has started to train again. He's so happy to cycle, to ride his bicycle all the time. He's able to do more 80 kilometers per day. So he has been negative for a long time and he's very happy. We only had one problem. He came to the visit with his wife. That was a bit, angry because he decided to stop doing his amikacin in his office. He went back to office, he was training. The point is that his wife is asthmatic, and after doing amikacin, she came into his office and started to, I cannot breathe. Of course, because you have to consider amikacin stays into the environment if it is not a ventilated room. So we had this little problem. He understood he has to do it safely, right? So after that, he's still on the same treatment, inhaled amikacin since then, and he's doing pretty well. So this is a real story. The third case, it is from a few years ago. It is one of the first patients I treated with these characteristics. 78 years old, so pretty old, ex-smoker. He had TB when he was young, right? So he had COPD, he had bronchiectasis due to TB, and he is blind. He was sent to me because he was continuously under antibiotic treatment. He had been hospitalized like 3-4 times in a year, every 2-3 months, every 2-3 weeks, he was starting to feel bad. The lung function test, you see, it was FFBC 56, FE1 was 32, right? The CT scan was showing bronchiolitis, was showing bronchiectasis, micronodules everywhere, and Pseudomonas aeruginosa was there. As usually, this clinical case is pretty clear. Since more than 4 years, he had been treated with, levofloxacin for a week, ciprofloxacin for a week, amoxicillin, the primary care sometimes not they're not very expert with this kind of infection. And it was, as usually, on inhaled bronchodilators, the typical combination. It had also been started on azithromycin. That is quite, at that time, what was quite new, but it was good. So what would you do in this patient? You might increase azithromycin from 250 to 500. You could start an intravenous therapy. You could start an inhaled antibiotic. You could start physiotherapy. He had a lot of sputum. Choose the best option for you. Choose the best option for you. Azithromycin, IV, inhaled, or physiotherapy. Okay, let's see your responses. Yeah, okay. IV, inhale, and physiotherapy. The 3 are very similar. Okay, so I'll tell you what I did. So azithromycin, in such an old person, you have to take care of side effects, heart problems. I did not feel secure about increasing azithromycin. Intravenous. These men could be treated, but they have been hospitalized so many times that he was saying, oh, please, not again. Oh, please, I want to stay at home. So I decided to start on inhaled antibiotic, but he was blind. So I phoned his GP and I asked him if he could ask the nurse in the ambulatory to prepare the nebulization for him. So at the beginning, he was doing, for a month, he was doing inhaled colistin twice a day. After a month, he started to do 2 millions of colistin just once a day, was going every day to the ambulatory to receive, with the help of the nurse, once daily treatment. It was going on from Monday to Friday. He was blind. His wife was as old as this guy. So, and physiotherapy was not an option because of general situation. I couldn't see him doing physiotherapy with good results. I couldn't expect from him good quality of physiotherapy. So I decided to do that. So these are the numbers. This is when I started. FEV1 went up from 32 to 50% after a few months. He had no more exacerbation. He was not hospitalized again until December, when he was hospitalized again. So before, he couldn't stay without antibiotic more than 3 weeks. Now, from June to December, he had not exacerbated anymore. After hospitalization, he decided to stop in October, but after the hospitalization, we decided to stop again. But after that, we started to develop dyspnea. So you see, FEV1 went down again 26. Of course, we decided to stop again because it seemed it had worked for a good period of time, but it was starting to have dyspnea and side effects. So we stopped, but he started to be more symptomatic in terms of cough and spitting again. So he asked me to start again. So we started again, but now with 1 million of units a day from Monday to Friday as usual, because he was blind. And since then, he has been much more stable. He had suffered no more hospitalization due to the respiratory condition. So I was really happy with this guy because, the quality of life of this blind guy was pretty poor. And I found this way to improve it a little bit, So it was one of the first COPD patients I started to treat with the inhaled antibiotics. So as a conclusion, the choice for inhaled antimicrobials is not easy. It's not easy. It is not the same as systemic administration. Always have to make a balance for each individual between pro and cons, right? Indications are not the same, challenges are not the same. So you need some practice. If you need some help, ask for help, because there are a lot of different things. At the end, experience is really important because you see the variables are numerous before you take a decision, and you have to follow up that person after that. And I think, Peter, that's all.
Perfect. That's a very, very great talk. Thanks so much, Eva. You have covered quite a lot in such a short amount of time, and we had quite a lot of questions. I already had some questions before the talk from people who filled in the online webinar questionnaire. So I'll fire a few questions, maybe one general question to start out with. Some people had questions on safety for personnel that is giving the inhaled antibiotics to the patient. What do they need to take care about? What do they need to make sure that needs to be done in order to be safe for the staff?
For the staff, okay. First of all, it depends on a kind of nebulizer, right? Because if you use, for example, the INAB just delivers the drug during patient inspiration and not during all the inspiration, during the first 2/3. So the last part of inspiration is given just to facilitate drug deposition into the lung. So the delivery is not continuous. There is no continuous flow of the antibiotic everywhere. If you use a usual, jet device, then it's continuous. So the antibiotic can be everywhere. And we had the case of a mom of a CF patient who became allergic to the inhaled meropenem that her daughter was doing, because was trying to help the daughter, and she became allergic because the meropenem was going everywhere. So ventilate your space, choose the right device, right? You can use, there are sometimes specific filter for pentamidine, for example, to avoid the diffusion of this drug everywhere. And the patient, take care, use the bronchodilator first, because they could become hypoxemic after that. They could become bronchospasm.
So it seems like we are not rid of COVID right yet. Do you think it will have an influence on giving nebulized antibiotics, because we want to, at this point in many hospitals, limit as much as possible nebulized medication for patients with possible silent COVID and the spread risk? Do you think it will influence the future of inhaled antibiotics towards more DPI?
Okay, it is an essential drug or an essential kind of administration in some patients. So if I do really believe that patient needs or would benefit of that, I would ask the patient to do a PCR. If that patient is negative, I would invite him to the hospital and I would perform the tolerance test and I will start the antibiotic under the supervision, right? After that, the patient will stay at home, right? Where we assume that the conditions are different, is not going to spread, whatever around. So the virus is now, we are more aware about the risks. That is good, because we need to be aware of the risk of nebulizing all the time, not only now because of the COVID. Anyway, we have to do the balance. The patient really need that. So let's go for it. Of course, before make a test to make sure there is no risk.
I see just a question from Julian Ceballos. It is indeed in this slide, it's 2 million colistin, so 1 million twice daily. So it's not 1 million each 24 hours, just to make a correction there.
Sorry.
One question that popped up is for the non-EU members, but even for other countries within EU, this is a relevant question. If you don't have the reimbursement possibilities, are there other options? And the specific question that is being asked, can IV antibiotics be used as inhaled?
When I started to use inhaled antibiotics, we did not have inhaled antibiotics specifically prepared for that. At that time, we used intravenous antibiotics with a risk. There is a higher prevalence of side effects. We still use, for example, meropenem, inhaled ceftazidime in CF, because we do not have the alternative. But whenever you have the possibility to use an appropriate solution, go for it, or ask your pharmacy to prepare it, because the risk of side effects is still there, particularly in more fragile patients. So I know it could be the case you use intravenous solution, but whenever it is possible, go for the prepared solution. It is much more safe, secure, and better for patients.
The Murray paper of gentamicin was also 80 milligrams twice daily, and it was the IV formulation that was used and reconstituted. The other question that popped up in the questions before was, how do you prepare a patient who has asthma, or how do you prevent these side effects in these patients?
To me, in my experience, it has been almost impossible to use inhaled drugs in asthmatic patients. Or I've tried it to, for example, after an exacerbation, I start to use systemic corticosteroids to reduce inflammation as much as possible, as much as the hyperresponsive, potential hyperresponsiveness. But the tolerance is usually poor. So the asthmatic patients with bronchiectasis, for example, they have tolerated it, abused it for a certain period of time, for example, 2-3 months, and then stopped because their tolerance was less and less. So you have to try. If you always just please consider not as the first choice. Just when you don't have a better alternative, might try to use optimize in the bronchodilator therapy, corticosteroids, sometimes for a short, for a period of time, like a week, and then try that therapy.
I see a question from Yvette who asks, how do you know for sure if adequate pulmonary concentrations are being achieved? How is that measured?
In theory, there are techniques, right?
But I think you also have to consider the fact that most of the antibiotics that you give in inhaled dosage are antibiotics that have a rather low concentration in the epithelial lining fluid. I saw a question pop up on azithromycin. There is a company who has developed inhaled azithromycin, but I don't see the real benefit because the concentrations of azithromycin in the epithelial lining fluid is very high. So the standard is ceftazidime, I think, which has a concentration ratio serum ELF, so epithelial lining fluid, of around 1, and azithromycin has 20. So it's a very good macrolide, is a very good antibiotic to go to the epithelial lining fluid. Whereas, for example, gentamicin has a rather low concentration. That's why we deliver it in inhaled antibiotics.
Yeah, it depends by case. But I mean, do you usually, let me ask, for example, do you usually check for light deposition of usual bronchodilators? You don't. You just simply use them, expecting them to work. We do have techniques that are able to show lung distribution of a specific drug. They are quite costly, that is quite expensive to do. But what's the sense in clinical practice, to be honest? And when we think of prepared solution for inhalation, because their preparation is thought to achieve the peripheral airways the best we can nowadays.
I have 3 questions on bronchiectasis who are more or less the same. The first one is, you have a patient with chronic Pseudomonas infection with recurrent exacerbations. What is your first choice? Will you go for macrolides, inhaled antibiotics, or a combination of both?
This is the never-ending story. I've been asked this question so many times. It depends on your patient. It depends, I mean, for example, if I had to choose, in theory, I would say I do prefer inhaled antibiotic because it is topic, it is localized, and I would avoid systemic side effects of azithromycin. But it is expensive, it takes a lot of time. In terms of burden of treatment, it is pretty high. Azithromycin is cheap. It takes a second to take it every day. So it depends. So if it is the first time you use this kind of drug, you have to choose depending on your patient. Many times patients do not tolerate azithromycin because of diarrhea, for example. Other people do not tolerate inhaled antibiotics because they develop bronchospasm. If the patient is more severe, then he could decide to use both, right? Or even 3. Oral azithromycin, 2 different inhaled antibiotics on alternate months. It depends. It is very depending.
Yeah. How is your take on other gram-negatives that are not Pseudomonas? How about inhaled antibiotics there?
The point
For example,
is,
Phenotrophomonas or other gram-negatives.
The point is, from a scientific point of view, I can tell you the only evidence we have is about Pseudomonas aeruginosa, because we do know that having that infection will change the life of that patient. The prognosis will be influenced by that. We do not have the same evidence for other bugs, but for example, for Haemophilus influenza, that is the second most common pathogen, doesn't seem to alter the risk of mortality, over time. Anyway, the point is that the patient is dealing with a very heavy burden of symptoms. So I think we have to treat the patient, not the disease. If the patient is clinically very symptomatic and I don't find other solution, I tend to try the inhaled solution for a period of time, right? Even for E. coli, I've used inhaled antibiotics for E. coli. And we wrote the guidelines saying there is evidence just for Pseudomonas. But if the patient is heavily sick, would you leave it because we don't have guidelines, because we don't have evidence? I would try the best we can in each specific patient, depending on the situation.
I will go one step further. Last step, if you have recurrent exacerbations in a bronchiectasis patient without a pathogen present, would you consider inhaled antibiotics if azithromycin isn't enough?
So no microbiology. So
yeah.
I would insist with that. I would ask a bronchoscopy first.
Okay. A lot of questions also on oral antibiotics. I will have to skip those because that's not really the aim of tonight. I had some questions on the ventilated patients because we're closing to 7 o'clock, but there are so many questions, so that's great. Someone suggested that there's so many variables when you have an intubated patient, like humidity, distance of the antibiotic that has to travel, the velocity. Would installation of droplets at the entrance be a more viable option, or is there other ways of improving the position?
Well, the question arises because we have been using installation in the past. To be honest, I do not think the distribution of installed, I mean, the installation is is optimal. I would say it's good for tracheobronchitis, so upper airways mostly, so more and not so lower. But I mean, we do have possibilities in ICU patients to use the right devices. The point is, we need some expertise. So let's call for somebody with experience. Let's call for people, promoting these devices, the T devices, to improve their or implement their use, because installation could be even more not say toxic, but could even produce more side effects like cough. It is a bit more aggressive in some patients.
In terms of the ventilator-associated pneumonia, the trials that you showed had some resistance concerns because you're giving handheld antibiotics just to prevent resistance. And in your clinical experience, what kind of resistance are we in danger for?
To be honest, these are what the authors said. In clinical practice, we do not care about it. I haven't seen anything significant in terms of emergence of resistance. The situation where we use an adjunctive therapy are so difficult, so severe, that we tend to use almost all the instruments we have, and then we remove them as soon as possible. But it is the opposite. When you take a spontaneously breathing patients, you go for the lowest level of treatment to the highest. In the ICU, it is the opposite. So do you know what I mean? So usually it is not relevant, to be honest. Of course, you have to continuously go for microbiology. So every 3 days minimum, you have to do a bronchial aspirates or whatever to make sure, because new infection can emerge with or without inhaled antibiotics.
One other question that popped up is, sorry, in terms of the COPD, the bronchiectasis, the CF patients, how long do you treat them with inhaled antibiotics? When do you decide to stop, to hold, the on-off?
Look, some years ago, I would have said, do we need to stop them? Then we had the economic crisis, and I was said, Eva, you have to stop antibiotics after 3 months, and let's see what happens. And it was, oh my God. But some patients, they tolerate interruption pretty good. So now you have to realize that there's not always good give antibiotic forever. So once the patient is really stable, and microbiology does not show very high burden of Pseudomonas, whatever, you could try to stop it. Because we have to think about the economy as well. We have to think about consequences in terms of microbial selection. So I've started to interrupt in selected patients the inhaled antibiotics after 6 months or after a year. It is very depending.
How do you measure success?
No exacerbations, quite good quality of life, ability to do, daily routine without.
Do you do a new bronchoscopy? Do you new sputum surveillance, or just clinical?
I always do sputum surveillance, but it is particularly, the clinical evaluation that will tell you if the patient is stable. It's much simpler than it could be. I mean, you could imagine when you ask the patient, "How are you?" "Pretty good." "Fine. Did you have any problem in the last months?" "Not really." "Okay, but you have been on colistin for 2 years. Maybe we could try to stop it and have some rest." "Okay, but if the patient has every day some mucum despite inhaled antibiotics, maybe it could be a risk to stop it."
Another question that popped up is, what is if you could choose one type of nebulizer, would you prefer pressure meter dose, DPI, soft mist, normal nebulizer? What is the best pro cons?
So for young people, active in terms of work and whatever, possibly the powder would be the best. You take it, you bring with you everywhere this, this device. So it's really easy, if possible. The point is that available? It is very expensive. So if I had to use a different device, then I would think of the patient. So you just use one drug. So for that drug, the best device is that one. If you use inhaled hypertonic and then another drug, maybe it would be better for you to have one device only or two different devices. It depends on the kind of antibiotic and the ability of patient to do it. That's the reason it's very important to have to do it yourself, to supervise yourself, or to ask a specialized nurse or physiotherapy to see what the patient is able to do with that drug, with that device, to clean it, to manage the drug.
Okay.
There is no one answer. It depends on the patient. That's the reason I put a number of elements: easy of use, ability to clean it, to manage, tolerance.
Yeah, and device maintenance, of course, is also very important. Yeah. Last two questions, maybe, because it's already 7:06. What parameters do you use to guide your choice of inhaled antibiotic? Is the question when you start them in a patient who has bronchiectasis or who is intubated? Do you look at the results of sensitivities, or do you use what is possible, what is available to you, or what you are used to using?
Okay. In intubated patient, we tend to have a new infection. So in that case, I would use the susceptibility test, the antibiogram, to identify the pathogen and to choose the appropriate drug. Of course, interaction with a number of other drugs is usually taken. That patient is really important, right? So that will possibly guide my choice. And if we think of a spontaneously breathing patient with bronchiectasis, again, the availability is crucial. The ability of patient of doing that treatment is crucial. And after that, first choice, for example, for Pseudomonas could be both colistin or tobramycin, if we think of the prepared solution for
Okay, perfect. And maybe a last question, which is maybe a more a question on future, because we had quite a lot of questions on countries who had troubles in using inhaled antibiotics because of reimbursement problems, or because the trials that have been done haven't shown the results we hoped for. We need after and sub-analysis to prove their efficacy. For example, the colistin trial showed that only in the patients who are compliant it helped, and then the other sub-analyses. So the question is, how can we better design these clinical studies, in your opinion, to get these drugs approved?
Okay, a good selection of patients, right, is fundamental. Then there is a clear evidence that a high bacterial load is important to see the difference. As I told you, a post-hoc analysis of the Astrenum trial shows that only patients with high bacterial load to have a clear response to treatment, a clear improvement compared with saline solution, right? And patient with real bronchiectasis, there with frequent exacerbations, not patients that were seen once in a year, and then because of the trial were put into the trial, and then because of the follow-up, just because of the medical follow-up, they started to get better. So the effect is not related to the treatment or to the placebo, but because of the medical observation. That is the problem we have seen with a number of trials. So better outcomes. What is the best outcome to choose? Number of exacerbation, quality of life. There is still a lot of debate. It's not clear, but patient recruitment has been a crucial point.
Okay, thank you so much, Eva, for these excellent few minutes and hours and your answers. Thank you, everyone. It has been a great success. I've seen so many more questions, but we've run out of time. But this really shows that maybe we can have a follow-up also on oral antibiotics, because there's a lot of questions on oral antibiotics in these patients. On pediatric patients, we had some questions we could not answer. So maybe, and I'm looking at the co-host Ali, we could send around another questionnaire asking the people who attended this session if they want another session like this, maybe on a different focus or maybe a more specific subtopic.
We will.
Yeah, because this has been a very successful evening, and I wish you all the best. Thank you, Eva, again for your excellent talk. Thank everybody for attending, and I hope to see you all soon in good health.
Thank you very much.
Thank you very much. Good evening.
Good evening.
And good day for the other ones.
Yes, for those who are very early at the other side of the world.
Okay, bye-bye.
Bye.